दो भैया कुछ ज्वाइन भी किया लोग कैसे पता चलता
ये इससे एक एक आते जाएंगे।
बट वो आज स्टूडियो 3 से है कि 1 से
ये लिंक ना सर एक स्टॉप
2 मिनट रुक जाओ डाल रहा है इसको फिर शेयर करना पड़ेगा
शेयर
स्लाइड्स कैसे है
स्लाइड से इसमें ना सर अरे स्टोरी सर गो लाइव हुआ है गो लाइव एक बार
करना है
हाँ अभी चल रहा है ठीक है ये था
So, good afternoon, everybody. इसको बंद कुलदीप इसको बंद कर देना डोर. So, we have a cardiology seminar today on coronary artery disease, and I don't know how many of you have been able to join, but I hope you are all safe and healthy wherever you are, whether in hostels or homes. So, very difficult times that we're living in. But I am sure these times will also pass. So, in keeping with the classes going on during these times, we've switched to online classes. So this will be a little different format for both for you and for me. And I hope I'm able to communicate the required classes that has to be taught. So today we're going to talk about the risk factors of coronary artery disease, and just to we're very fond of terminologies and their brief names. So coronary artery disease could be, when you read literature, could be known by very different names. It could be written as CAD or CHD, coronary heart disease, or quite often nowadays also written as IHD. These are all quite interchangeably used. The other terms which are used in similar context are cardiovascular disease or CVD. So this goes beyond involvement of the vascular system beyond the heart. So like a stroke would be part of cardiovascular disease, and then there will be other host of diseases that could be part of cardiovascular disease, which could be non-vascular origin like rheumatic heart disease. And several diseases like aortoarthritis and other vascular diseases. But the bulk of CVD is also now, because of the burden of atherosclerotic diseases, is coronary artery disease and cerebrovascular disease, that is stroke and such similar diseases. The other term often used again is ASCVD or atherosclerotic cardiovascular disease. So that rules out non-atherosclerotic cardiovascular disease like RHD and, as I said, Takayasu and other kinds of non-atherosclerotic cardiovascular disease. So these are quite interchangeably used, and it's because the basis, the pathophysiology for coronary artery disease and the other diseases are similar in terms of atherosclerosis and its pathogenesis, which you would have know, but this is briefly showing you the coronary artery disease pathophysiology, which you all must be familiar from your other learnings from pathology. So this shows the whole sequence of atherosclerosis, starting from a normal artery, and then how you have a fatty streak, then a fibrous plaque, then this becomes an occlusive atherosclerotic plaque, and then finally you may have the dramatic event of an heart attack or a brain attack, where you have a rupture of the plaque causing fissure and thrombosis, which can lead to stable angina, MI, coronary death, or sudden cardiac death, or stroke. Or if it involves one of the peripheral arteries, then it can cause peripheral limb ischemia or critical limb ischemia. As you see, the initial stages can be silent part, and then here is where till here, which is silent, then you can hear from here you can start have symptoms of effort angina because of the obstruction in the vessel, and here of course is the catastrophic event of an heart attack. So this is how a normal coronary artery looks, which you should we do it day out as cardiologists. We look at these anatomies. So this is how a normal coronary artery looks. These are the three arteries. The left anterior, this is the left main coronary artery, this is the left anterior descending artery, and this is the left circumflex artery, and this is the right coronary artery. And they're looking quite pristine and without any obstruction. And this is how a diseased coronary artery looks. So here you're saying triple vessel disease as we call it. So there's disease in the left anterior descending. Then there is diffuse disease here, and then there's obstruction, complete obstruction of the right coronary artery. So just to show you a brief cardiologist's view of coronary artery disease. So who do you think he is, and why are we here? Well, he's one of the very popular presidents of America, President Roosevelt. And why am I showing you his figures? Well, he died of hypertensive heart disease and a hemorrhagic stroke during his presidency, and his blood pressure recorded at that time, I don't know how they recorded this value, was 350 by 195 millimeters of mercury. And this is his blood pressure chart over a few years. And there was very little they could have do to manage. While they had diagnosed his disease, there was very little that they could do to manage his disease, because there was hardly any treatment available for hypertension or vascular disease at that point of time. And his death in many ways was instrumental in expediting research into coronary artery disease and stroke, which was a huge epidemic in the USA at that time, and of which very little knowledge was available of its cause or its management. And it's really initiated the iconic study, if you could say, for vascular diseases called the Framingham Heart Study, which is a small neighborhood outside of Boston. The study was initiated by the founding director, Thomas Royal Dauber, who was also nicknamed Roy. This study was initiated in 1948, and they included people in the neighborhood between the age of 30 to 59 years, and detailed medical history examination, X-ray, electrocardiography, blood tests, including cholesterol and glucose measurement was done. And these patients, these individuals, I wouldn't say patients, these normal people were followed up over several years. And this study, you'll be surprised to know, is now in the third generation, where children and children's children have now been recruited in this study, and it has gone, of course, very high tech now with genetic analysis and all kinds of stuff. But this study was really instrumental in telling us what risk factors are and why coronary artery disease happens. And it was really where the concept of CVD risk factors has become an integral part of the modern medical curriculum. And what we are studying today can be attributed to this study and several such studies. But definitely this was the first study to understand that coronary disease and such kind of vascular diseases happen because you carry some risk factors, which we are going to study today. So what are the risk factors of coronary artery disease? Well, we can broadly define them as modifiable and non-modifiable. So as you age, you have a risk for having this disease. This, of course, you can't change. If you are a male, you have a higher risk of having this disease. Then if you have a family history of premature coronary artery disease, which is defined as having coronary artery disease in men less than 55 years of age and women less than 65 years of age, then you have a higher chance of having the disease. And then ethnicities, some ethnicities, including our South Asians, are more prone to coronary artery disease, and which we'll see later. So there are other modifiable risk factors which could be behavioral or biological. The behavioral ones are tobacco use, physical inactivity, atherogenic diet, high alcohol intake, and then we have high blood pressure, diabetes, dyslipidemia, obesity, which are the other risk factors. There are emerging risk factors. Uh, I mean, I would say emerging, they've been there for some time, like lipoprotein little a and homocysteine. And then there are frequently ignored contributors, and there is this hypothesis, the Barker hypothesis, which mentions how about the fetal origins of adult diseases, and the childhood obesity is another risk factor. So just reviewing them, what are the major risk factors for you that you must definitely know about? These are the 5 major risk factors of coronary artery disease. They are high blood pressure or hypertension, diabetes, tobacco use, dyslipidemia, and family history of premature coronary artery disease. There are other risk factors: diet, psychosocial stress, and type A behavior was once considered a very strong risk factor for coronary artery disease. Obesity, physical inactivity, and then, as I told you, the noble risk factors, including high sensitivity C-reactive protein, which I'll mention here. And this is often an association, definitely, or a predictor of future coronary artery disease, whether it has a causal relationship or it just reflects that atherosclerosis, as you would know, is also an inflammatory disease, and high inflammation leads to high CRP levels, and which in future predicts future coronary artery disease events. So, and then of course there are genetic polymorphisms which have also been now been identified, which put you at a higher risk, and one of them is the 9p21.3 polymorphism that happens. So what are the strengths of the associations? If I can take a break, I hope you are able to hear me, and the audio and all are clear. If one of you could put it in the chat box, then that would help me, make some changes. Yeah. ठीक आ रहा आवाज़ आ रही yeah. So okay, so just carrying on, so at an individual level, most of these risk factors increases your chance of having this disease by 2 to 3 fold. That is the relative risk of person who has this one of these risk factors is 2 to 3 times higher than those who don't have it. For diet and physical activity, it's 1.5 fold higher. So if somebody, if you were to understand this, if an individual who has no risk factors, he has a chance of 5% over the next 10 years to have cardiovascular disease. And a person with one of these risk factors, like diabetes, would have twice as much chance, 10% chance of having coronary disease. Then there are other risk factors which are smaller risk, and of course there are factors like familial, especially homozygous familial hyperlipidemia, which increase your risk 5 to 10 times, but these are rare disorders. So let's just look at one individually these risk factors which make you prone to coronary artery disease or cardiovascular disease. And high blood pressure is one of the major contributors worldwide to the cardiovascular disease burden, because there are over 1 billion hypertensives in the world, and it causes 7.1 million deaths worldwide each year. So it's a huge problem, and accounts for 13% of the annual global deaths. And if you can see among the risk factors, global risk factors for disability, it is the number 1 risk factor for death and disability in the world. So how does cardiovascular risk factors affect, how does blood pressure affect cardiovascular risk? And this again comes from a cohort study where they were followed up, people were followed up after a basal measurement of blood pressure over the years. And if you can see, here here for every 20 by 10 millimeter mercury rise over a basal so-called normal blood pressure of 115 by 75, there was a 2 times higher risk of dying from cardiovascular disease. So for every increase in 20 by 10, your risk for having coronary artery disease and dying out of cardiovascular disease doubled. And then the reverse was true when you started treating people, and this is from a meta-analysis, that is a study which pooled in data from several studies, 147 randomized trials of hypertension treatment. And it showed that when you treat people with high blood pressure, and as you reduce their blood pressure, you reduce, as you see here, the chance of incident, or which means new coronary artery disease and stroke for for every millimeter decrease. So as you decrease the blood pressure more, you decrease your chances of coronary artery disease, and the benefit is even larger in terms of reduction of stroke. So both ways it shows that there is an association, and there is treatment benefits you in terms of reducing events of coronary artery disease and stroke. So it kind of establishes the causal relationship between blood pressure and coronary artery disease. And this is one of the more recent trials called the SPRINT trial, where they showed that if you actually lowered blood pressure intensively, like they had very strict target of 120 millimeter systolic blood pressure instead of the usual care of 140 millimeter mercury. And they showed that if in these high risk individuals you lowered these blood pressures very aggressively, then it led to a 25% reduction in primary outcome and a 25% reduction of death. So obviously blood pressure and intensive lowering blood pressure in this study clearly showed was beneficial as compared to usual care. And because of this, there has been, and recognition of blood pressure as a risk factor, there has been over the years decrease in the targets of blood pressure management. That is, the targets for managing, for targets of blood pressure for of patients who you see in your clinics has been going down from 160, then it was 140 for several years, and now the new guidelines have even gone further to say that in people with high risk of cardiovascular disease, you need to have targets of 130 millimeters of mercury and 80 millimeters of mercury. So they are the new targets. Everybody doesn't follow them and believe in them, but the two largest associations, the American Heart Association and the American College of Cardiology and the European Society of Cardiology have modified their guidelines to suggest that in high-risk individuals you must treat hypertension aggressively, and your targets to achieve by blood pressure reducing medicines is now 130 by 80. These are the stages of hypertension. I will not go into details of this because it's a very textbook, but the different societies have actually defined different levels for blood pressure, and in fact the American societies have gone to the extent of defining hypertension at the 130/80, and if you're 130 by 139 and 80 by 89, if your blood pressure is in that range, you're called stage 1 hypertension, which was earlier and even now by ESC called high normal blood pressure. So they have clearly lowered and changed the definition of hypertension also, and the stages are also much more aggressive. So 140/90, anything above 140/90, which was earlier defined as hypertension, is actually defined as stage 2 hypertension in the American College of American guidelines. This is a little too aggressive, but that is how it is. So diagnosis of hypertension will again vary by depending on what tool you're using to measure blood pressure. So for 140/90, if is what is used as office hypertension, then for self and home it is a lower cutoff because you're supposed to be less anxious at home and when you self-monitor your blood pressure. Similarly, for ambulatory blood pressure, if you use 24-hour ambulatory blood pressure machine, which is a machine which is tied to your cuff, and you go home and it takes blood pressure at predefined intervals, then and measure the blood pressure over 24 hours, and you take a mean of all those blood pressure recordings, and then the cutoff for this is 130/80, not 140/90. The antihypertensive drugs you are familiar with. I'll not go into the treatments, but these are the drugs which you are quite conversant with because of the multitude of things that we have to cover. We'll not cover the details of treatment. These are clearly available in most of the textbooks and in guidelines, and this is how you make a choice. Again, I'll not cover this, but there are certain indications where you need to use one class of drug over others. So, for example, calcium blockers may be preferred in people who have asthma. Beta blockers may be preferred in people hypertensives who have MI and angina and CHF. So, coming to the second major risk factor, diabetes and coronary artery disease. It again, as you see here, the heart disease and stroke are the number one causes of death and disability among people with type 2 diabetes. And adults with diabetes are 2 to 4 times more likely to have heart disease and stroke than adults who do not have diabetes. And diabetes leads to a risk equivalent to aging of 15 years. So this is again, if you see from the diabetics in the Framingham heart study, if you see, they clearly the diabetics have a higher event rate of having different cardiovascular diseases. And overall, if you see, the risk is about 1.5 in men and 2.2 in women in this study of having coronary artery disease if you're diabetic versus if you're not. And similarly, heart failure risks are higher. Stroke risks are 2.9 and 2.6 in men and women respectively as compared to normal population. So obviously what it's showing is diabetes gives you a significant risk of having cardiovascular disease. And this chart clearly shows the lifetime risk of having coronary heart disease, which increases obviously once you age. Your risk for normal population increases of having coronary heart disease more in men than in women, but in diabetics you will be able to see that it's even very higher and confers the highest lifetime risk of coronary disease of any single risk factor. So being diabetes markedly increases your chance of having coronary artery disease. There are several mechanisms, and again this is quite well will be elucidated in several textbooks, but it would suffice to say that hyperglycemia per se, the insulin resistance that is there, dyslipidemia, which is common association of diabetes, the adverse thrombosis mechanisms that are at work, then diabetes leads to inflammation and several markers are raised as compared to non-diabetics, and the infection burden that they may have lead to subclinical atherosclerosis and atherosclerotic clinical events. But the good thing is, from a very recent study from published in New England Journal just last year, is that, and the study was by Rashwani et al. In a registry from these Scandinavian countries, that they showed that in diabetes, if you control these 5 risk factors, which is a good glycemic control with a target of less than 7% of glycosylated hemoglobin. I hope you know what HbA1c is. It basically gives you an average sugar control over the last 3 months. So if you can keep that under 7%, if you can keep your blood pressure under 140/90, if you do not have albuminuria, that is, you protect your kidneys, and if you don't smoke and you have cholesterol levels less than about 100, then there is no excess risk of dying or excess risk of MI in people who are diabetics versus non-diabetics. But as the number of risk factors increase, let's see the bottom of this page. If you have all the 5 risk factors and you're less than 55 years of age, then you have almost a 5 times higher chance of dying and 7.7 times higher chance of having an MI if you're a diabetic and you're not controlling any of these risk factors. Versus if you're controlling all these risk factors, there is no excess myocardial infarction. So obviously it's not that if you're a diabetic, you have to have worse cardiovascular outcomes, you have to have more MIs. No, if you control these 5 risk factors, the study showed you can substantially reduce the risk of having these complications related to diabetes. So now let's go to, I think we skipped a slide, but the next major risk factor, which is lipids. And if we see here, as your level of cholesterol increases, you have a higher risk of developing coronary artery disease and dying because of coronary artery disease. Similarly, as you have lower HDL, you have higher risk of coronary disease. And if your ratio of total cholesterol to HDL as it increases from 3, 4, 5, 6, 7, your risk for coronary artery disease increases. You might be wondering why there are three lines here on the graph. So this is for different ages. So obviously, a person who's older has a higher basal risk of cardiovascular disease, but in all ages, as you can see, your risk increases as your as your lipid profile worsens. And again here, like as we saw in hypertension, when you reduce your cholesterol, it is associated with significant reduction in in cardiovascular disease events. So here you can see when you reduced with treatment, which is predominantly statins as of today, you led to reduction in non-fatal MI, reduction due to coronary artery disease. You had lower major coronary events like need for bypass, for CBG, and in if your chance of a brain attack, that is a stroke or a cerebrovascular accident, would reduce by 17%. So, and any major vascular event increased by 21% when you treated people by reducing their cholesterol. So, this is a powerful intervention to reduce cardiovascular disease events. And this chart interestingly shows that these cardiovascular risks factors work in combination. So as your cholesterol levels goes up, your chances of having cardiovascular disease increases. And as your blood pressure goes up, as we discussed, your cardiovascular disease events goes up. But what's important to understand that when multiple risk factors act and both your cholesterol and your blood pressure are going up, then you are really in deep trouble, because then you have the highest risk for having cardiovascular disease. So there is this you need to understand this approach of multiple risk factor reduction strategy in order to optimally prevent cardiovascular disease. Then let's very briefly talk about another risk factor, which is tobacco, and this I'll discuss with a very interesting study done actually among doctors, UK male doctors born between 1900 and 1930, and the study was done among them, and these people were this is a very famous study by Richard Doll, and they followed these patients up over several years, and they showed clearly that in the middle age, by the middle age, if you were a smoker versus a non-smoker, you were surviving. You were 10 years less. So this is a very common message for you, for budding young doctors. You would clearly not like to be on the blue line. You would love to be, I would love to see you on the red line. And so you clearly, over the years, if you follow the red line here, you save 10 years of life. You prolong 10 years of life. And why is that so? And it's a very good cartoon I got from one of my teachers, Professor Reddy, who clearly shows what all are available in this cigarette, which makes it so harmful. And you things like what you use in floor cleaners, things of which are available, arsenic, which is a white iron poison actually, things you like to kill insects with, things which are part of gas chambers, and even things used in nuclear weapons are present in a stick of cigarette. So obviously one must keep away from it. And this is a very nice study which showed the risk of having a heart attack in smokers versus non-smokers. And as you can see, the highest risk is among the young people, and very often, in the middle of night, as cardiologists, we are called to treat young heart attack patients even in the 30s, because the only risk factor among them is smoking. And you can see at that age, if you're a smoker, your chance of having a heart attack is 6 times more than the person who doesn't smoke. And actually, the chance of sudden cardiac death, because heart attacks are especially vulnerable to heart attacks in smokers. They are vulnerable to dysarrhythmias and lead to 10 times higher risk of sudden cardiac death. And this is again from a very large study called the Intra-Heart study, which was a case-controlled study where they took people admitted with heart attacks and controls, age-matched controls, and they clearly showed that as the number of cigarettes smoked per day increases, the odds ratio of having a heart attack increases. And this is again from the same study. So if you're never a smoke, if you never smoked versus if you have smoked usual filter cigarettes, you have a 2.9 times higher chance of having a heart attack. What about BDs? There are a lot of myths that they may be less harmful, but this study, which had a lot of patients from our institution and a lot of studies from India, they clearly showed that even BD smoking was as harmful as cigarette smoking. Tobacco chewing, again something very unique to India, was again had 2 times higher risk of having heart attacks. And when you combined smoking with tobacco chewing, then these individuals had the highest risk, almost 4 times, of having heart attack as compared to people who do not use tobacco. Physical inactivity again is a very important risk for coronary artery disease, and this is a very nice slide from Myers et al. Published in New England Journal, which I called survival of the fittest. And if you see, if you're fit, then you clearly are doing much better, and the relative risk of mortality is much lower in people who are fitter as compared to people who are unfit. And so each 1 minute increase in exercise capacity, they concluded, improved your survival by 12%. And it's also the other problem is of inactivity is studied with sitting. And so at every level of physical activity, if you have more than 6 hours of sitting as compared to less than 3 hours of sitting per day, your chances of having cardiovascular disease increases, and dying of cardiovascular disease increases substantially. So lastly, let me just talk about one of the rarer causes of rarer spoken risk factors of cardiovascular disease, and that is what I had mentioned as Barker hypothesis, or the fetal origins of adult disease. And this is well depicted by this world map, which shows that countries with high burden, like India, of underweight people will have higher burden of diabetes. So this was first given by Barker, or what is called the Forstall-Barker hypothesis, and this talks of the fetal origins of adult diseases, and it just says that low birth weight individuals have higher risk of developing hypertension, coronary artery disease, diabetes, and stroke. So I'm not going to great details, but this has come from several cohort studies done in the Western countries, and there are over 100 publications to suggest this. So this is one of the novel risk factors that have now come up for coronary artery disease, and there are some which I had discussed earlier, but we'll not go into the details of that. But I would just like to tell you that a lot of the Western countries over the second half of the previous century were able to reduce their mortality significantly from coronary disease, and were able to reduce it to the extent of 50% as compared to what they started with. And large part of it was because they were able to manage these risk factors much better. And there was significant impact of reduction in smoking, population levels of BP reduction, cholesterol reduction, which led to benefits. So obviously this is a very important window we have of managing these risk factors so that we reduce the chance of coronary artery disease in individuals and in the population. So I would just finish by telling you, so how, now that you know all the cardiovascular risk factors, that you have a brief snapshot of these risk factors and how they work, how do you calculate an individual's risk factor? And there are very nice scores now available. There are online calculators, and there are several of them. The American, the Framingham, that is the British one, QRS 3, and then WHO cardiovascular risk factors. These are available online. As your number of risks increases, you get into the red zone. So we'll just, to finish and to give you a concept of cardiovascular risk, try to see what your cardiovascular risk for an individual whose particulars I have added here would be. For example, here is a 54-year-old male who is a non-smoker, non-diabetic, and he has no other risk factors. This is the QRS 3 which I've used, and this has several risk factors, including ethnicity. And here he's an Indian, and he has a cholesterol HDL ratio of 4, and he has quite a high blood pressure of 176. Well, here is the second individual who is a smoker, has type 2 diabetes, has mildly high cholesterol levels, and has a good blood pressure of fairly okay blood pressure, borderline of 140. What do you think is a higher risk of having future coronary artery disease? So if you put this in this, if you see the first individual who had a very high blood pressure but no other risk factors, has 11.8% chance of having a heart attack or stroke in the future. So, and for this age, if you see, the usual risk should be 7%. So his relative risk is 1.7 times higher than a person of the same age with no other risk factor. While the other individual who had multiple risk factors, not as high blood pressure, but was a smoker, had slightly high cholesterol, somewhat higher sugar levels, his risk is much higher. So the idea is to tell you the multiplicative impact of risk factors that they have. So a small rise in different risk factors puts you at a much higher risk than one single high risk factor. So these are that you could sit down, calculate risk factors of your friends, family members, and this could give you an insight of how cardiovascular risk factors work in causing coronary artery disease. This is just another case vignette of a 55-year-old asymptomatic man with who's a smoker. His blood pressure levels, his sugar levels are here, and if you add this here we've used the score, which is the ESC guideline, and if you see his risk of having cardiovascular disease event is 9%. But if he's an Indian, because this, being a South Asian itself has a multiplicative factor of 1.4. That is, a person of South Asian origin has a 40% higher chance of having cardiovascular disease. His risk factor becomes 13%. So these are the important things you must learn about the CVD risk factors and how we can minimize, how we can predict adverse outcomes and how we can minimize them. So I'll conclude that there are multiple cardiovascular risk factors. They work as a continuous and constant over a wide range without any serious thresholds, and treatment should be based on global cardiovascular risk and not on individual risk. So you should manage the multiple risk factors at the same time. So if a hypertensive comes to you, you just don't manage his blood pressure by giving a pill. You also look at his diet, you look at his tobacco consumption, you look at whether he has sugar, so you can kind of advise him, lifestyle advice can be given for that, and you manage these multiple risk factors at the same time and not go for managing single risk factors, because these risk factors, as I said, are multiplicative, and managing them gives you enormous public health opportunity and individual opportunity to reduce future coronary events. So after this, we'll have the second talk by Professor Gautam Sharma. So we'll just give us a 2-minute break. We'll just upload those slides. कुछ तो
Narang is will they be able to communicate? How can they this is on Lipids. Good afternoon. Can you hear me? Well, I presume you can hear me. So we're going to be talking about how do you evaluate a patient who has chronic stable angina. So Dr. Ambuj Roy has just talked about the risk factors, and but I just wanted to give you a perspective about the mortality associated with chronic stable angina. And so before the era of aspirin, beta blockers, and statins, the Framingham study revealed an average annual mortality rate of around 4% in patients with chronic stable angina. And since that time, when we've had all these drug interventions, the prognosis has improved, and there's an annual mortality rate of 1 to 3%, and a rate of major ischemic events 1 to 2%. So, at the offset, I would like to emphasize that it's not a very, very malignant course as such. If you take an individual who has got a common garden variety of chronic stable angina. Now, chronic stable angina includes obviously the epicardial stenosis, which is the commonest form of chronic stable angina. Then you also have microvascular angina, vasospastic, associated with ischemic cardiomyopathy, and then you have angina equivalents of dyspnea, fatigue, palpitations, syncope, which I'll be talking about. So how do you evaluate? So that's the question of this seminar. How do you evaluate? So the most important thing, the most really important thing is to assess the symptoms and then perform the relevant clinical investigations. So the first and foremost thing is to make sure whether the patient has chronic stable angina and not unstable angina. And there's a lot of difference in terms of management and the prognostic outcomes of the two. So what is classical angina, the typical angina? So typical angina is recognized by three characteristics. One is a constricting discomfort in the front of the chest, in the neck, jaw, the shoulder, or the arm. Secondly, it is precipitated by physical exertion. And thirdly, it is relieved within 5 minutes by nitrates. Now, when you say atypical angina, that would mean that meets 2 out of these 3 characteristics. And when you say non-anginal, that means only 1. So, and what is unstable angina? So one of the 3 ways you can classify unstable angina, one is rest angina, The other is new onset angina within 2 months. And third is crescendo angina, which is worsening of a previous chronic stable angina. A patient who's having class 2 symptoms suddenly has class 3 symptoms. So these three categories are, you would classify a patient as under unstable angina. You all know how to grade the severity of effort angina, and that's by the Canadian Cardiovascular Society. I'm sure you're all aware of that. Then after you've assessed the symptoms, which I want to reiterate is the most important, and you'll realize as we go along, then you have to consider the comorbidities. So what if you know that the patient has chronic stable angina, but it's he's an elderly patient who's got severe debilitating comorbidities, then what would you consider? You would probably consider that revascularization is not going to improve the quality of life of this patient, or it's not going to improve the morbidity. So if you reach this option that revascularization is not acceptable, then further testing stops. So the evaluation remains still here, and what you can do is institute a trial of anti-anginal medications. Now, if these comorbidities are not there, then you go to the step 3, which is you get a resting ECG, the biochemistry, X-ray, and echocardiogram. In biochemistry, you obviously do the complete biochemistry, including hemogram, the renal function test, because if you have to go in for contrast angiography, then you need the renal functions to be normal. The lipid profile, the diabetes status, and the thyroid function status. But more importantly, you need to rule out ACS in certain settings by repeated measurements of troponin. Now, there is you would read in your textbooks about the inflammatory markers, including HSCRP, that have been studied often. And I just wanted you to be aware of this, that it has been seen in studies to be of prognostic value. When you add it to the traditional risk factors, what Dr. Ambuj would have already spoken about, and a high level of HSCRP may be a marker of prognosis in established CAD patients. So you may include HSCRP in your evaluation to prognosticate a patient with chronic stable angina in certain situations. Similarly, you know that troponin is used in acute coronary syndrome. However, even in chronic stable angina, troponin levels, obviously of levels below that which are diagnostic for ACS, have been used, and what, as you can see from the graph on the right side, it has been seen that higher levels of troponin in chronic stable angina patients indicate a poor mortality and morbidity even in chronic stable angina patients. So this is a concept which is developing, but here you need, I want to repeat that troponin levels are not the level wherein you diagnose acute coronary syndrome, but at a lower level. So you need more sensitive assays for such levels. Then obviously you come to the ECG. So the ECG, if it's normal, that's very good, because a normal ECG means a normal LV function, and a normal LV function means a good prognosis. But there are common abnormalities in the ECG, which include STT changes. There may be abnormal Q waves. Now, so if there are STT changes, they can correlate with severity of the underlying heart disease. But if the ECG is normal, it indicates a favorable prognosis. Obviously, when there is an episode of angina, the ECG becomes abnormal. But it doesn't become abnormal in all, it becomes abnormal in 50% of the patients. So if you have a resting ECG, which is normal even during a sort of anginal episode, uh, you can't exclude angina, true ischemia, if the ECG is normal. So you must remember that it becomes abnormal only in 50% of patients. Then there are conduction disturbances, most frequently left ventral branch block and LAHP, which may be associated with patients with stable ischemic heart disease. And when they are associated, they often indicate impaired LV function and reflect multivessel disease or previous myocardial damage. So then the next important investigation after the resting ECG is the echocardiogram. So if the echocardiography is showing an ejection fraction overall of more than 50%, it is a good prognosis. And if it is less than 50% and as it goes lower, the prognosis becomes worse. So after the echocardiogram, you now go to the step 4, which is to assess the pretest probability and clinical likelihood of coronary artery disease. Now, this is an important step, and you'll understand as we go along why. So you have to, it is very important to assess the likelihood of coronary artery disease prior to the further investigations. Now, why is that? Because if when you talk about a stress electrocardiogram or a TMT, then it is limited in its interpretation if you do it for all patients. So what you need to do is, and you must be aware of the Bayesian principles, which states that the reliability and predictive accuracy of any test are defined by not only by its sensitivity and specificity, but also by the prevalence of disease in the population under study. So if this, we'll come to that, but this is an important concept, Bayesian principle. So how do you make a clinical assessment of the pretest probability of coronary artery disease? So this is their typical algorithms and tables that have been given, and this is one which is commonly in use. And you can see that they've given the different age groups, and they've given both genders, having typical angina, atypical angina, and non-anginal chest pain, and angina equivalent or dyspnea. And the dark green is coded for high probability, that is more than 15%. The low probability is the grays, which is less than 5%. So, for example, if you see a 70-year-old male with typical symptoms, he would have more than 50% probability of having a coronary artery disease. And if you see a 70-year-old male with the atypical symptoms, there's only a 30% likelihood that he'll have coronary artery disease. So where is your TMT or your stress electrogram useful? It is useful in the intermediate category, because in the low category you'll have higher false positives, and that'll be a drawback, and the opposite in the high probability cases. So so remember, a treadmill test or a stress electrogram is best used in patients who have intermediate probability of underlying coronary artery disease. So once you assess the pretest probability and the clinical likelihood of coronary artery disease, as you've just done, you go to the next step, which is you offer the diagnostic testing. Now this diagnostic testing is, it'll depend, your choice will depend upon whether the clinical likelihood of CAD is low or very high. So if it is intermediate, then you might like to go in for testing for ischemia. If it is very high, you might straight away go in for invasive angiogram. If it is very low and you want to rule out a coronary artery disease, you might go in for a coronary CT just to rule out coronary artery disease. So you must also remember that non-invasive testing should be performed only if there is incremental information which is provided by the test is likely to alter the planned management strategy. And the second statement I've already explained to you, that it is the value of the non-invasive stress test is the greatest when the pretest likelihood is intermediate. Another thing that I want to emphasize is that irrespective of whether the test is positive or negative, the duration of exercise, the exercise capacity of the patient, is very important clinically. Irrespective of the fact whether the test was stopped terminated because of dyspnea, fatigue, or even angina, it is the strongest predictor for mortality in patients with cardiovascular disease. So when you look at the treadmill test, you not only look whether it is a positive or a negative stress test, but also you look at the exercise capacity. And if exercise capacity is good, you are a little relaxed, because that indicates a low mortality in these patients over a period of time. However, exercise electrograms cannot be done, have no diagnostic value in patients who have underlying left bundle branch block, who have pacemakers or paced rhythm, patients who got a WPW syndrome, or patients with resting STT abnormalities, or patients who are on digitalis. So if the patient has an underlying, so it's not uncommon that the patient has a left bundle branch block. So treadmill test cannot be done in these patients. So in such patients, then you think about other tests, including myocardial perfusion SPECT. And what this is the principle. So what happens is that so if there's a stenosed vessel and you stress the patient and you take the image, you'll find that there is a defect. So this circle is incomplete, and the incomplete portion is indicative of a perfusion defect. And this is during stress. But after 3 hours, when the patient is resting, if that perfusion defect gets remedied, gets all right, gets rectified, and the other scenario, it remains the same. So it means there is ischemia at rest, where the perfusion defect gets rectified. If the perfusion defect remains the same, it does not improve, that indicates that it's a dead myocardium, there's a scar there. So this is the principle of the myocardial perfusion imaging tests. And two types of tracers are used, thallium and technetium. Right now, thallium availability in India is suspect. So we at the All India Institute are doing with technetium. So sometimes the patient is not able to undergo a stress test. I mean, he's got, say, a knee problem or severe osteoarthritis. Then you need pharmacological stress so you can increase the heart rate with dobutamine, or you can directly vasodilate the coronaries with adenosine. So these two agents are used for pharmacological stress. Dipyridamole is not available in the country. So this is this is how these stress images look like, and it's been labeled for you to understand. So basically, the left ventricle is, which is the ventricle of interest here, is cut in slices. In the top image, it's cutting from the apex to the base. In the middle one, it is cutting from the inferior to the anterior wall, and in the lower one, it is cutting from the septum to the lateral wall. You can see the images, and this is how they appear to be. So the images are actually coupled, stress and rest. The upper row of the images is the stressed images, and the lower ones are the rest images. So when you so this is how a scar appears like, and the middle one is a scar where you see in the upper row in the stressed image there is a defect, and in the rest image, which is the second row, you can see that I don't know whether you can see by here you can make out. Um, I have no way of knowing whether you can communicate with me. Maybe you can just chat and tell me that whether you can make out my arrow. I, anyway, so so this is a stressed out image here, which is showing a defect. This defect is not improved with rest, so that means it's a scar. Here you can see that this is a image which shows a defect during stress, but it has been remedied, it's been rectified at rest, so that means it's a reversible defect, it's ischemia. So this image is showing a scarred myocardium in the, so here you can make out, this is the apex, the rest, and this is stressed and the rest, and it's not improved. Here you can make out that this is the septum, and here the rest septum, which is also not improved, and the anterior wall here. So all in all, it shows. So this is how you make out. You can make out the different walls with the SPECT imaging, and when you make out the different walls, you know that these territories are supplied by which vessels, and you can make out, like on this image on the right side, you can see that it's basically LAD and RCA that might be the culprit lesion here. So, so how does a TMT or a stress electrogram compare with SPECT, dobutamine SPECT, adenosine SPECT? There's another modality in which you can do exercise echocardiography, which is similar to SPECT in the sense that you exercise a patient either physically or by giving pharmacological agent, and then you look at the regional wall motion abnormality. So it's more or less the same as, however, the myocardial perfusion scans are more objective, and echocardiography is a little subjective modality. But if you look at the sensitivity and specificity of the treadmill, it varies. It's around 70% overall. But if you look at the myocardial perfusion SPECT, it reaches between 80 to 90%. So the sensitivity specificity of a myocardial perfusion testing or an echo, exercise echo, is much higher than that of a simple stress electrogram or TMT. So once you have the patient has undergone these tests, then you can risk stratify the patient based on the non-invasive testing. So you can divide them into three categories. The high risk is more than 3% annual mortality rate, and these patients are typically those who have LV dysfunction, who have a high risk treadmill score, and who have stress-induced large perfusion defects. And at the other end, there's a low-risk group wherein the treadmill score is low, and there's a very small myocardial perfusion defect at rest or with stress, and similarly with the echo stress. So with the non-invasive, you can risk stratify the patient based upon the non-invasive testing. So regarding which test to choose, so you must remember that there is a rule in power of the non-invasive functional tests, and these patients are at you basically prefer patients who are at higher likelihood of CAD to undergo these tests. And coronary CTA you prefer in low range of clinical likelihood of CAD, or you just want to rule out coronary artery disease. Obviously, if there's a high calcium score or irregular higher heart rate, coronary CTA is contraindicated. Now, coming on to the invasive testing, which is a coronary angiogram. So, coronary angiography is, supposing you have a high risk non-invasive test and you have a clinical scenario wherein the patient you feel is at high risk. So these are the patients you subject to coronary angiography. And stenosis which is more than 70% diameter narrowed is called significant stenosis, because that's the physiological cutoff at which there is ischemia on exercise. So when you do a coronary angiogram in chronic stable angina patients, so 25% each, there's a chance out of 100 would have single, double, or triple vessel disease. And 5 to 10% would have an obstruction of the left main coronary artery. And in 15%, there would be no flow limiting obstruction detectable. The other thing you can do with coronary angiography and angiogram is an LV angiogram, wherein the LV function can be assessed, and the global abnormalities of the LV function can also be assessed. The systolic function, the regional wall motion abnormality, and also if you measure the pressures, you can make out the filling rate, the impairment in the filling rate because of diastolic dysfunction in stable ischemic heart disease. This is a very important graph, and this is basically showing the importance of left ventricle ejection fraction. So the red curves are ejection fraction which is normal, and the light green ones are the ejection fractions less than 35%, which is severe, moderate to severe LV dysfunction, and the blue one in between. And the first one is single vessel disease, and you can see that with single vessel disease, if the LV function is poor, there is a poor survival in terms as if you compare it with double vessel disease and single vessel disease. And when you compare with normal LV function and abnormal LV function. Similarly, this is for double vessel disease, which shows the same thing, that if there is LV dysfunction, similarly the prognosis survival is poorer, and the triple vessel disease, it is obviously the same, but it gets worse with increasing severity of the coronary artery disease. Here I wanted you to understand that if there is a double vessel disease, there is a 88% 5-year survival with medical therapy. But if there is, if there's a double vessel disease that includes a proximal LAD disease, which obviously means a larger territory at risk, so then the 5-year survival becomes lesser. The patients with triple vessel disease and which include more than 95% proximal LAD disease have the worst 5-year survival, which is around 60%. So typically, these are the patients who have poorer survival with medical therapy are the ones that you think about revascularization, whether by CABG or by angioplasty. But coronary angiogram is not always has got its own limitations. It's so one important thing is that it depends upon it's a comparison of the severity of stenosis at the point of stenosis with the lesion which is relative, which is adjacent. So sometimes you can erroneously think that it is free of disease, and that might lead to underestimation of the severity and extent of atherosclerosis. The other thing is that you can't, so you have a stenosis, you have a plaque, but you won't know whether it's a high risk or a vulnerable plaque. That means that this is a plaque or a stenosis which is at risk for a future ischemic event or sudden death. For example, this is angiogram of a right coronary artery and shows a tight stenosis here. So it is intuitive to, first of all, first point is that how do you assess the severity of the stenosis? You will compare this with the adjacent vessel diameter, but you're presuming this to be normal. This may not be normal. This looks normal because that's a limitation of coronary angiogram. It may not be a normal, so you may be underestimating the severity. The other thing is that it is again intuitive to know that to think that this is a tight lesion and this is going to be causing a heart attack or a ACS in future, but here proximally there is another lesion which is just mild lesion, and one would tend to dismiss this, but actually you don't know whether this lesion is going to cause a heart attack or this somehow insignificant lesion is going to rupture, plaque is going to rupture and going to cause a heart attack. So this is the limitation of coronary angiogram. This is on the right side is another view of the LAD and the diagonal bifurcation, and you can make out there's a bifurcation disease here. So as I said, it is not necessarily the plaque that causes the most severe stenosis that subsequently ruptures. Lesions causing mild obstructions can rupture, thrombose, occlude, thereby leading to MI and sudden death. In contrast, arteries with severe pre-existing stenosis may just proceed to clinically silent complete occlusion. Why does that happen? That happens because there'll be formation of collaterals as ischemia becomes more severe. So once collateral form and supply the distal segment, then it'll be a clinically silent complete occlusion, and it will not be an MI. So to deal with the limitations of this coronary angiogram, you have other modalities like intravascular ultrasound, optical coherence tomography, and angioscopy and thermography. These are evolving, and at present they are mostly investigational tools used in scientific studies. So a bit about the intravascular ultrasound. So what does the intravascular ultrasound do? How the benefit that it has over coronary angiogram is that it provides a cross-sectional image of both the arterial lumen and the wall, allowing correct assessment of the true lumen dimension and architecture, as well as it shows the plaque burden, the plaque itself, and vessel wall abnormalities. Where would you use intravascular ultrasound? You would use intravascular ultrasound where there's, you do an angiogram and you feel that this is maybe 70% stenosis, maybe it is less than 70%. You don't know whether to place a stent there or not. So this is typically a situation in which you do an intravascular ultrasound to help you assess the severity of the lesion. And these typically, this happens especially when there is an ostial lesion or a bifurcation lesion, as the one that I showed you. So here are some IVUS images. This is a coronary angiogram and shows a stenosis here. And this is an image of the IVUS image, which is showing distal, which is around here, the distal normal vessel. And this here is the IVUS catheter, and this is the lumen. And the image below shows the stenosis, which shows that the lumen is this much now, the yellow circle, and the rest is the plaque. This is the vessel wall, and the plaque in between. On the right side, you have an IVUS image which is showing these hyperechoic lesions are actually struts of a placed stent, and this stent has not been opposed to the wall, which is these outer arrows, and so it's a malopposed stent placement, and malopposition of stents is one of the reasons of stent failures. In the image below, you can this is an angiogram image. This is showing a left circumflex artery, and this is stent placement. Proximal to the stent there is a haze. Now you don't know what is a haze, then you do an ultrasound and you find that this is actually a flap. So this is a dissected segment of the coronary artery proximal to the stented segment. Now I'll end with just a clinical scenario, two clinical scenarios. So you have a 57-year-old man, and he's got a chest pain for the last 3 months, and exertional chest pain, which is typical. He doesn't have diabetes or hypertension, never smoked, and cholesterol is also in a reasonable limit. So what would you do? So these are the steps that I talked to you about. You would assess his symptoms. The symptoms, and what did the symptoms show? The symptoms showed reveal that the patient has typical angina. You consider the comorbidities. He's apparently an active man. Then you think about the investigations that you can plan out, including an echocardiogram, and then you subject him to a stress testing. So before subjecting him to a stress testing, where would you place him? So he's 57 and he's got typical symptoms, so he becomes a high risk category. So do you need to him to go and undergo a treadmill test? This is a high probability of test coming positive, then high probability of coronary artery disease in this. So you straight away go in for an angiogram in this case. So the angiogram revealed the images that I showed to you just some time back, and he's got a double vessel disease. This is another patient, a 39-year-old woman, and she has chest pain by walking uphill, which is on exertion, on more than normal exertion for the last 3 months, which probably would be class 2. So it is relieved by rest within 5 minutes, but she also has a different pain at rest. There are no risk factors, and so what would you do in such a case? So here you have a 39-year-old woman, and the woman has atypical symptoms. So she would be at a very low probability for coronary artery disease. So what would you do? You can rule out coronary artery disease here in this case by doing a CTA, and you can. And this is a CTA. This is a CT which is showing normal coronary artery architecture. So I leave you with these two clinical cases, and then the management would further be continued by Professor Narang. Thank you.
First one is
अटेंड कितने कर रहे? अटेंड करना कैसे पता लगेगा?
What? These are
You look at, huh? Sorry. So, good afternoon, everybody. I'm Dr. Narang. I'm Professor in Cardiology. So, we'll be talking about management of chronic stable angina. I'm sure you so you have heard from Dr. Roy and Dr. Gautam Sharma about the risk factors and subsequently about the evaluation of patient with chronic stable angina. We'll be talking about the management. So, I'm using a lot of images, and many of them they are from the internet. So basically, we need to understand the main categories of management. Now, for any disease, actually in medicine, the categories are medical, interventional, and surgical. These are three types of treatments that we use for various diseases. So medical is using lifestyle measurements, treatment of risk factors and drugs. Interventional are like the percutaneous intervention, like percutaneous coronary intervention. It used to be called PTCA earlier on, now it is called PCI. Or surgical treatments such as coronary artery bypass grafting, CABG, etc. Alright. So, all these three medical intervention surgical managements are available for patients with chronic stable angina, and we have to choose appropriately. So, what are the goals of therapy? The goals of therapy are to reduce the mortality, that is the most important, to reduce future cardiac events like acute MI or heart failure, to ameliorate the symptoms so the patient they can have full functional capacity, and also to minimize the cost of treatment. So reducing the mortality and the morbidity are the main goals of therapy, but we have to keep it in mind that we have to be cost effective also. Certain non-fatal MI and heart failure, they are important cause of morbidity for such patients, and therefore we have to tailor our therapy to keep these to the minimum. So what are the various lifestyle measures that can be taken? Most important is stopping smoking. Smoking is a very important risk factor, as you must have discussed, for coronary artery disease, for any atherosclerosis actually, whether it's stroke or it's a peripheral arterial disease. So stopping smoking is a very cost-effective method, a very important method to reduce the mortality and morbidity in these patients. Diet is important. It should be, as you all know, it should be low in saturated fat, cholesterol, and trans fats. It has to be high in fruits and vegetables, and also evidence that the sugar and salt should also be low. So you can tell your patient to reduce their salt, sugar, and fat in the diet. That's a quick and easy way to convey to them what exactly is the dietary intervention that you are asking them. Exercise is another very important method. It must be remembered that some studies have shown that the benefit of exercise is as much as more expensive intervention like angioplasty or surgery also. So American Heart Association recommend that one should do at least 150 minutes of moderate exercise per week. That is around 30 minutes per day for 5 days a week at least. So these, of course, they may not be possible for a patient who has got chronic stable angina. So those patients, you should ask them to increase progressively. Slowly, they should try to walk as much as possible. If they get symptoms, they should sit down. They should not keep forcing themselves. And once they are better, then they can try to walk again. They can try again in the evening or next day. And progressively, they should try to increase the length and the extent of exercise and the severity of exercise. Many patients, patients these days, they have got a treadmill, and as you must have discussed that the treadmill test is very important. So once a treadmill test is done, then we know that what is their exercise capacity, and these patients can be advised regarding that. So progressive exercises lead to a lot of improvement in symptoms because exercise affects many pathways in the body, many metabolic pathways, and most importantly, it leads to improvement in collaterals. As you know that the coronary disease is caused by stenosis and obstructions in the coronary artery. So collaterals develop from the other arteries so as to provide good blood flow in the in the obstructed artery. So one should never underestimate the role of exercise in these patients. You know, in the peripheral vascular disease also, the progressive exercise has been documented to increase the collaterals and increase the claudication distance. Similarly, it acts on the heart also. Then we have to encourage the patient to maintain their optimal body weight, and the BMI should be between 18 to 23 for Indian patients. For Western patients, generally it is 25 is mentioned, but for Indians, 18 to 23 is what is recommended. Reduce their psychosocial stress. This is an important factor. So this psychosocial stress is reduced by meditation, by yoga, and by various other interventions also. Some of these patients who are extremely anxious, they get help by the from the psychological counseling, and sometimes they are giving a little anti-anxiety agents also to reduce their anxiety and stress. So treatment of risk factors is another aspect. We should control the risk factors of the coronary artery disease, and we must have discussed that the hypercholesterolemia, hypertension, and diabetes, increased blood sugar, they are very important risk factors for coronary disease. So we have to reduce the cholesterol, and especially the LDL, low density cholesterol lipoprotein, is what is important. So target LDL is less than 100. For the blood pressure, the target blood pressure is less than 140/90, and the target HbA1c for the blood sugar is around 7 for diabetic patients. So there is some debate exists about these targets, but these are roughly the target which you must remember, that for LDL try to reduce it to 100 or less, and for blood pressure try to keep it less than 140/90, and HbA1c should be around 7. If it is too low, then patient has more chance of hypoglycemia. If it is higher, then it is uncontrolled diabetes. So also self-monitoring of blood pressure and blood sugar are encouraged for these patients. So the digital blood pressure instruments are available these days. They are not very expensive. Most patients are able to afford them, and they can check their blood pressure at home only. And if they are told that their blood pressure needs to be less than 140/90, then they are able to monitor themselves. Similarly, home monitoring of blood sugar is important component of diabetes, which you will be listening in lectures on diabetes. So then we come to the drugs. What are the various drugs that are used in patients with chronic stable angina? Now see, chronic stable angina is a very basic and a very important and very prevalent disorder, and therefore you will be asked about these in the examination, and you are expected to know most of the things about these. So although these are simple, but you need to answer them perfectly, so that so for something as basic as chronic stable angina, you should be able to answer it well. So most important drugs, when we ask you what are the important drugs, people start talking about the anti-anginal agents, but very important are aspirins and statins, because these chronic stable angina is occurring because of atherosclerosis, and for atherosclerosis, the aspirin and statins are the ones which have been known to provide survival benefit to our patients. So these are essential for these patients. Aspirin generally 75 to 160 milligram per day, and statin can be rosuvastatin or atorvastatin. Atorvastatin dose of 20 to 40 generally, sometimes up to 80 milligram per day, and rosuvastatin dose is generally half of this. Then beta blockers should be given if the patient also has, in addition to angina, if the patient has LV dysfunction or heart failure, because beta blockers are of survival benefit in these patients. Beta blockers are also anti-anginal agents, so therefore they become first line of agent in patients with LV dysfunction or heart failure. Similarly, ACE inhibitors or ARBs should also be given if the patient has got LV dysfunction or heart failure, also because in this they provide survival benefit. Similarly, they are also useful if the patient has hypertension or diabetes or CKD, because here also the ACE inhibitors are beneficial. It must be noted that ACE inhibitors per se are not anti-anginal agents, but since LV dysfunction, heart failure, hypertension, diabetes, CKD is very often present in patients with chronic stable angina, ACE inhibitors and ARBs are often given to these patients. Now we come to anti-anginals. It must be noted that anti-anginals are only for symptomatic relief. They do not cause prolongation of survival, unlike aspirin, statins. As anti-anginals do not cause mortality benefit, they only provide a symptomatic relief. and you must know that the common agents which are used are nitrates, beta blockers, calcium channel blockers, especially amlodipine, ranolazine, which is a metabolic agent, nicorandil, ivabradine, and trimetazidine. Ivabradine this leads to a little slowing of the heart rate like beta blockers, but it does not have a bronchoconstriction effect. So in patients where beta blockers are contraindicated because of severe asthma or COAD, one can give ivabradine. In addition to these patients should also receive annual influenza vaccination. This is very important. Studies have shown that annual influenza vaccination reduce the cardiac events also in future. So there is some relation. The exact mechanism of the relation is not known, but it is beneficial for these patients. After the medical therapy, we come to the percutaneous coronary interventions, or the interventional therapy, and they are generally in the form of percutaneous coronary intervention. You have seen the patients who have got coronary artery stenosis, and now if the symptoms are persisting despite medication, then the patients may need to be taken up for coronary angioplasty, and this can be using only balloon angioplasty, which sometimes is called POBA. POBA stands for plain old balloon angioplasty, but this is less commonly used. Coronary stent placement is almost invariably done in these patients these days, and the coronary stent placement can be with the bare metal stent, it can be drug-eluting stents, or it can be with the bioabsorbed stents. All the bioabsorbed stents have been withdrawn because of they cause increased incidence of adverse effects and subacute thrombosis. So bare metal stents, they have a major drawback that they cause restenosis in about 25% of patients. So they are also now much less used. So main stay of therapy, intervention therapy is by placement of the drug-eluting stents across the stenosis. So what are the steps? How is it done basically? So a special guiding catheter is used, which has a larger lumen, and this with the guiding catheter, baseline angiography is done to visualize the coronary stenosis. Then one passes a coronary guide wire, and these are generally 0.014 inch in diameter, and they are passed across the stenosis. So they form a railroad over which we can pass other hardware like balloon and stents. So we pass the balloon over the wire to the site of stenosis and then dilate that area. Then we remove the balloon catheter and then pass the stent, which is mounted on another balloon, to the site of stenosis. And then we deploy the stent at high pressure, generally 10 to 14 atmospheric pressures. So this leads to opening of the stenosis, I'll show just now, and a placement of the stent. So here, for example, this is just showing the approach that is generally taken is generally from the femoral artery. Sometimes radial artery can also be used. So via the femoral artery, one goes up the iliac, up the aorta, into the aortic root, and hook the coronary artery. And once you are hooked the coronary artery with the guiding catheter, then one can inject the contrast and see the vessels and the stenosis there. So this is a balloon angioplasty catheter. This is passed over the wire, and you have a balloon catheter here, and this is a balloon which is deflated. And once you are you pass the wire across the stenosis. Over the wire you pass the balloon. The balloon is now in place. The balloon is initially in the collapsed state, and then from outside we inflate the balloon, and when the balloon is inflated, the plaque is shifted out, and the plaque is the area is opened, and then you can deflate the balloon and you bring it out. Now the artery is open. The plaque has been displaced laterally, and the artery is open. The blood flow is better now. So this will be balloon angioplasty, but normally there are some drawbacks of just plain balloon angioplasty, that sometimes there is a recoil. This is initially it opens, but then subsequently it recoils back and kind of restenosis, it recoils back and stenosis persists. Second is often it causes dissection in that area, and that dissection flap can come on the lumen, and it will cause narrowing, and this narrowing later on there may be thrombus formation and sudden occlusion of the vessel leading to a infarction. So therefore to avoid these things, a stent placement is done in the opened area. So here it is. This is again the showing the same thing. We have got passing the initially wire, then the balloon is dilated and the vessel is opened. But as I told you, that recoil can occur or dissection can occur, that will lead to narrowing. So here what is done is, over the wire a stent is placed. Now this stent is crimped upon a balloon catheter. So it is in a collapsed state, crimped on the balloon, and then once it is located in the proper position across the stenosis, it is dilated from outside. It contains diluted contrast, so you can see on the fluoroscopy that it has become dilated, and that leads to expansion of the stent. So once the stent expands, then you can collapse the balloon again and withdraw the balloon and the wire. And now the stent in an expanded position will be in place in the coronary artery, and this will keep the vessel open. So this will prevent the recoil. That is the most important thing. It will prevent the recoil. And secondly, suppose there is a dissection somewhere, it will prevent the dissection flap from coming into lumen and obstructing the blood flow. So there is a nice result is obtained after placement of the stent. So here, for example, we can see this is the coronary angio, and this is the left anterior descending artery, and you see that there is a narrowing here. This black area is all contrast. This is the branch, diagonal branch, and you can see there is a tight narrowing here. There is no. So, and this is after the angioplasty, after the wire has been passed, the balloon, then stent has been placed. So the stent has opened the vessel very well. As you can see, this is you can see a straightened part, and this is because there is a stent in place here with a very well opened coronary artery. So then the stent, as I told you, could be bare metal or with drug-eluting. Then people attempted to make bioabsorbable stents, that these stents were made of special polymer which would gradually get absorbed by the body, gradually get absorbed from the vessel, and finally leaving only the vessel in place. So initially the bioabsorbed stent is placed, and you have then now that you remove the balloon and the guide wire, and what you find here is the stent is open and the vessel is open, and the stent gradually, with a period of time, it will gradually get absorbed, and finally over about 9 months, 1 year or so, this is completely absorbed and the vessel is back to normal. So this is obviously an ideal scenario. If this happens, this is the best. So this stent was tried. However, it was found that this causes problems. It's a little bulky stent and it causes problem. There is subacute thrombosis forms. So those events are more, and therefore this has been withdrawn now from the market. So what other interventional procedures can be done that may be needed? So different types of them, they are available. One is called a rotablator. It's a rotational atherectomy, and this has got a tip which rotates at very high speeds, and that removes the plaque, that ablates the plaque and opens the vessel. Similarly, there is something called cutting balloon. This is a balloon which has got sharp blades on the sides, and that cuts the plaque and kind of opens it. Then atherectomy devices are there, but these are no longer used now. And along with these, we use certain modalities to check whether the narrowing is still significant or it has been opened properly, as you must have discussed with intravascular ultrasound as IVUS, or optical coherence tomography, OCT, or fractional flow reserve as FFR. With these modalities, one is able to find out whether the narrowing in the coronary artery is still significant after treatment or not. So this is a rotablator setup. So this is the burr which has got a fine, tiny, very tiny diamond placement placed over the tip, and it rotates at very high frequency, and it is passed over the atheromas, and where it ablates the atheroma and opens the vessel. However, you must note that these are required in extremely few cases where the usual balloon and stent placements are difficult because of the presence of calcification. With the calcified lesions, then rotablator is useful. So here in the angiogram, you can see this is the guiding catheter. It is in place, and this is a rotablator burr which has been passed into the coronary artery, and it is moved forward and backward to open the atheroma. Similarly, atherectomy catheter was also tried. It has got a gap from the side where the plaque is cut. So it cuts the plaque and takes out the plaque material from the coronary artery. However, this has not been found to be useful because there is a high restenosis rates in these patients. So this is the part of the intravascular ultrasound. The intravascular ultrasound, and this is a catheter which is again passed over the wire only, and one is able to see cross-sectionally the coronary artery whether there is any plaque or not. So this, for example, is the IVUS you must have seen earlier also. The IVUS has been passed into the coronary vessel, and you are able to see how much is the lumen, how much is the plaque. So here you can see this is the lumen, we have the plaque here, and we can see some calcification is here, and plaques of different category is there. So when once you place the stent, then you can evaluate whether it has been opened properly or not, whether the lumen is adequately dilated or not. Similarly, optical coherence tomography. So the visualization is better, and this is especially good for any dissection flaps which are common. Like here you can see a little dissection flap which occurs after balloon angioplasty. So this is the longitudinal reconstruction that has been done, so you can see the coronary artery, how it has been opened. There are some possible dissection flap here, some narrowing here. This part is well open, so you know from where to where you need to stent it. So these are the modalities that are used during the therapy to open the vessel properly. Again, the same as optical coherence tomography which is used in these patients. So this is an angiogram which has been done, and you can see this is the left antidescending artery, and as you can see, this is a normal vessel. Distally also the vessel is alright normal, but in between there is a narrowing. This is the area of narrowing, and here is the comparison is shown of how the IVUS appears versus how the OCT appears. So they are similar modalities, but OCT has got some advantages, both the near structures like dissection flap, while IVUS is better for little deeper structures like the plaque characteristics. So sometimes in the during angioplasty, one needs to put embolic protection devices, because when you are dilating the plaques, the plaque material can go distally and cause distal occlusion, and that may lead to occlusion distally, and the benefit may be much less. So to prevent these emboli from occurring, one can use different devices. Generally there is a filter device is used. The other devices are a proximal occlusion device or distal occlusion devices. However, filter device is the one which is commonly used. And here in the vessel, so the similar thing is actually these are used more in actually carotid arteries and less in the coronary arteries. But if they are used for coronaries in post bypass grafting. Once bypass graft has been done, where there's a vein graft has been put, so vein grafts, there the possibility of distal embolization is more, and therefore embolic protection devices are used more often. So here, for example, from the guiding catheter there is a wire, and over the wire then the filter wire has been put. So there is a filter device distal to the occlusion. Once the filter device is in place, then you can dilate the plaque. Any material that may go distally will get caught in the filter device, and then it can be brought back into the guiding, and it will not go distally into the tissues. Similarly, there is a distal occlusion device where the carotid artery, the vessel is occluded distal to the plaque, and then one can do dilatation here, and the plaque material which go embolizes distally, that will get stuck here. So it is absorbed. It is suction is done from this area so as to remove the distally embolized material. Similarly, there is a proximal occlusion device is known. So you occlude the vessel proximally, then you do opening of the plaque, etc. So the plaque material, embolized material will not go distally because there is no blood flow occurring currently. After doing balloon dilatation, you apply suction and to withdraw the material that may be remaining in the thing, and then finally remove the balloon, and so as to allow the flow to occur again. But these ones are used less common. Filter device is the one which is commonly used. So this is again similar types of other different types of filters are there, or occlusion devices are there. So as I told you, they are used less for the native coronary artery, more for the vein grafts, etc., which are there. Following bypass grafting, the narrowing is there in the vein grafts. Again, some kinds of filter devices which are used. So what is coronary artery bypass grafting? So this is a surgical modality used for the treatment of coronary artery disease. Patients with stable angina who are not controlled by medication alone, they may need coronary artery bypass grafting. So it's an open heart surgery. The patient is placed on the cardiopulmonary bypass machine, which takes over the function of the heart and lungs. So basically, blood is taken from the IVC, both superior and inferior vena cava, and they pass to the bypass machine, and where there is a oxygenator, blood is oxygenated there, and the oxygenated blood is pumped back into aorta. So therefore, there is no blood now going into the heart or lungs, and that function of the heart and lungs is taken up by the cardiopulmonary bypass machine. And then one surgeon can stop the heart and operate on the heart, open the heart, change the valves, or do put the grafts, so without any movement of the heart. Generally for the grafting, because one has to graft across the stenosis, one can use either arterial grafts or venous grafts. These are placed from aorta to the coronary artery distal to stenosis, therefore bypassing the obstruction. And the arterial grafts have got a much longer durability than the venous grafts. And the best is the left internal memory artery, that is Lima graft, which is usually used for the left descending artery. So Lima is the best arterial graft that can be given for CABG patients, and this is given mainly to the left hand descending artery because that is the most important vessel which can be diseased. Out of all three vessels, left hand descending artery, right coronary artery, and the left circumflex, LAD is the most important. Of course, most important, as you have must have discussed, is the left main coronary artery, which is which gives branches of LAD and circumflex. So it is very important to graft the LAD artery. And actually, if the patient has got double vessel disease with only RCA or circumflex, then generally the surgeons are reluctant to take these patients. These patients generally manage on medical management or by angioplasty alone. However, if LAD is also involved, then it becomes more important matter. And if the patient has got triple vessel disease, then the patient goes for CABG. So in the CABG, in the surgery also there are some newer advances which are like beating heart surgery and robotic surgery. These are also coming up. So in beating heart surgery, so this is an example of beating heart surgery. Basically, the heart is not stopped. The heart keeps beating while the surgeon performs the bypass grafting. So there is a heart stabilizing device and the bypass grafting is done. So this is a little newer aspect. However, the standard is still using the heart-lung machine to bypass the heart and lung. In this beating heart surgery, the heart-lung machine is not used. The IVC blood is going into the heart is beating and is pumping into aorta, and the heart walls are stabilized, and the grafts are put on the coronary arteries. This is the robotic surgery where the patient is in the operation theater, and through tiny holes in the chest, thoracotomy holes in the chest, the different arms of the robot is put, and the surgeon actually does surgery from outside. So this is tried for different surgeries, including GI surgery, urology surgery, and also cardiac surgery. So this is the advantage is that it can be done from a distance. However, this is a more recent advance rather than the usual coronary artery bypass surgery. So this is another example of that. So what to choose, when to choose between CABG versus coronary artery bypass grafting? So by far and large, the CABG is the angioplasty PCI, that is percutaneous coronary intervention, is used when the stenosis are few and they are limited to 1 or 2 vessels. While CABG is generally used if there is either a left main disease or there is a vessel in all 3 vessels, which is the triple vessel disease. So basically left main disease or triple vessel disease, the patients generally go for CABG. For single and double vessel disease, the patients may go for angioplasty. So this is a example of a study where they had done. So they had checked the complexity of the coronary narrowing using syntax, this score called syntax score. And so this could be low, this could be intermediate, this could be high. And then they compared whether CABG is better or angioplasty is better, PCI is better. So the blue lines indicate the events that are occurring in CABG patients, and the yellow lines indicate the events that are occurring in the angioplasty group. So in all three, if you note, the events are lesser in CABG group. So surgery provides a more durable benefit in these patients if intervention has to be done. So of course, if the complexity is more, if the syntax score is higher, then clearly there is a clear difference between the CABG and the angioplasty. So CABG should be preferred if there is a complex coronary heart disease with multiple vessel involvement, multiple lesions, while if it is a localized disease in 1 or 2 vessels, then generally angioplasty is done, and the difference between CABG and angioplasty is much less. So what are the strategies for refractory angina? There are some patients, despite giving medication, despite doing angioplasty, and some patients, they have had surgery also in the past, and they have got severe disease which cannot be subjected to further surgery or further angioplasty, but they still are having angina. So certain modalities have been tried and used for these patients. They are available for these patients. One is called enhanced external counterpulsation, or EECP, and the second is spinal cord stimulation, and third is transmyocardial revascularization. So in enhanced external counterpulsations, the bags are applied to the lower limbs and they are compressed regularly with every beat of the heart, so as to provide an increased systemic vascular resistance, and that leads to better flow in the coronary arteries. And this has been approved by FDA as a therapy for refractory angina. Spinal cord stimulation provides a kind of a counter pain for patients with angina, and this has got some success. Transmyocardial revascularization, it's an interventional procedure or a surgical procedure where small pores are made in the wall of the myocardium so that the blood may go into the myocardium and provide flow to the muscles, provide oxygen to the muscle, but this has not been found to be successful. So therefore, this has been given up now. Spinal cord stimulation does not have adequate evidence of its benefit, but EECP is the one which has been approved for patients with refractory angina. So it is important to understand how to approach these patients with stable angina. Now you know the various modalities that can be used and the various treatments that are available. So medication are the first line of therapy. So all these patients should be on medication or drugs, including lifestyle and advice regarding diet, exercise. And so this is called OMT, optimal medical therapy. Optimal medical therapy. Medications are the first line of management for patients with stable angina. Angiography and revascularization, that is angioplasty or CABG, they are needed only for patients whose angina results in a moderate to severe limitation of daily activities despite adequate medication. So if the patient has got moderate or severe limitation of activities despite adequate medication, that is NYHA class 3 or 4, then the patient needs to undergo early angiography and followed by revascularization. However, if the patient has got mild symptoms or no symptoms on medication, Suppose a patient with stable angina comes, and after starting of the therapy, he has no symptom. He becomes asymptomatic, or he has only mild symptoms. That is NYHA class 1 or 2. So there you should subject this patient to a stress test, such as stress thallium or maybe scan. So this is a nuclear stress test, and this should be performed, and angiography and revascularization then should be done only if there is a more than 10% of myocardium which is showing signs of ischemia. So only if the stress thallium or maybe is positive, then these patients need to undergo angiography or revascularization. That is negative, then there is no need. These patients should continue on optimal medical therapy. So this is important. So NYHA class 1 or 2 you do a stress test, and NYHA 3 or 4 you take them off on start OMT, but if they continue to be in class 3 or 4, you need to do angiography and revascularization. So persons whose angina is controlled, well controlled on medication, as well as persons who have got a negative stress test, they are not at a high risk of heart attacks and death, and therefore they do not need to undergo angiography and revascularization. And this is important to understand because sometimes that if the patient says that patient is able to climb 2 stories and he has a negative stress test, so those patients, they should not be advised any angiography or revascularization. Thank you. So I hope you have understood. If there are any questions, you can post them. You can post them here, and I can try to answer them. क्वेश्चन डालते हैं क्वेश्चन डालते हैं ठीक है. So I think we'll end the seminar here. ठीक है. स्टॉप कर दिया 1 मिनट स्टॉप है क्या दिखाना